So this article was written to address concerns uh, expressed by clinicians about opioid tapering. Hello, this is Mark Sullivan. I am a professor of psychiatry at the University of Washington in Seattle.
Hello, I'm Ed Covington.
And I'm here to talk about the manuscript that we will be publishing entitled Ensuring Patient Protections When Tapering Opioids, Consensus Panel Recommendations, which is the result of an American Academy of Pain Medicine expert panel.
For this article, we were concerned about the fact that prescribers in the United States have been whiplashed over the course of recent years. There was a period in the 90s when there was extensive messaging to the effect that opioids were the solution to chronic pain, that they have no ceiling dose, and that legitimate medical use does not lead to addiction. Then prescribers started hearing about a wave of addiction and overdose deaths that seemed to be associated with the increase in prescribing of these medications.
A lot of this tapering to lower opioid doses has occurred among patients with chronic pain treated with long-term opioid therapy. And there have been concerns that abrupt, involuntary, poorly supervised, or otherwise ill-considered tapers of patients who have been on opioids for months to years is occurring.
There are anecdotal reports of patients who have been essentially abandoned. Sometimes the abandonment wasn't official. It was more of a, I'm not prescribing this anymore. Go see Dr. Jones. He will take care of you. And of course, Dr. Jones wouldn't. So the patients have been left in the lurch and have experienced withdrawal symptoms. Sometimes they suffered through them. They've had increases in pain and suffered through that, but many of them sought out illicit sources of opioids, which ended up being far more dangerous than the prescribed doses they were receiving.
We went over the fact that patients can experience a significant adverse effects from opioid taper. These can include not only a pain exacerbation, they can include psychiatric destabilization, worsening of anxiety, insomnia, anhedonia. Particularly abrupt discontinuations can motivate or encourage illicit opioid use. So it's something to take seriously and thoughtfully.
So in response to this, government, payers, the CDC, regulators, medical boards began creating recommendations and sometimes mandates that opioid doses be limited.
The expert panel was assembled to discuss these concerns and make some recommendations about how to avoid them.
So we have wanted to provide guidance on the obligations of physicians to legacy patients who show up at their door already taking and dependent on high doses of drugs.
In general, I think the panel acknowledged that opioid taper, particularly for people who've been on long-term high-dose therapy, is a serious matter. It is something that should be taken up systematically with the patient's participation, if at all possible.
We've wanted to clarify that the guidelines that we have all been developed in response to adverse events that have occurred and not in response to measures of benefit that has occurred.
The CDC has in fact clarified that their dosing guidance, included in the 2016 CDC opioid guidelines, is not tapering targets. So they do suggest not going over either 50 or 90 milligrams of morphine equivalent. And those, they have said, should not be taken to be tapering targets if the patients are otherwise doing well on opioids.
The goal of this process is not to get people off opioids or on a reduced dose, but to keep them off opioids and on a reduced dose. And that can only happen if they're able to tolerate the process that we subject them to. We felt that there were times when guideline recommendations should be exceeded, when patients are showing clear benefit in terms of pain, mood, and function, and are not showing harms or inordinate risk or aberrant behaviors. So overall, the consensus panel does believe that it is the responsibility of the prescriber to ultimately determine whether a patient should continue opioids, and that opioids, like any other medical intervention, should only be continued when the benefit exceeds the harms and the risk.
Allow me to speak for the entire AAPM panel to say we sincerely hope that you'll find our article useful in your clinical practice and that it's helpful in negotiating this difficult clinical challenge of opioid taper.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.